Hello, everyone, and welcome to our symposium. The title of the symposium is Golden Hour, European Resuscitation Council Guidelines for Newborn and Neonatal Resuscitation with Electrocardiogram Monitoring. First of all, I would like to thank the GE Healthcare for organizing this symposium. The second part, I want to thank the speaker. We are very important, very skilled, outstanding speakers today. And so please, you are invited to follow their presentation. And due to the time restriction that we have, unfortunately, we have not planned a final discussion at the end of the session, but you can write your question, your comments, everything you want through the chat, and we will respond, or the speaker, we will respond to your comments within 1 week by email. And so I think that I don't want to lose time, and so I am very happy to present, to introduce the first presenter. Is Professor Tomasz Szczapa. Is a pediatrician and neonatologist. Is also associated professor and deputy head at the Department of Neonatology in Poznań University in Poland. Tomasz Szczapa is also member for the European Resuscitation Council Neonatal Life Support Science and Education Committee. And in addition, is vice president of the Polish Neonatal Society. And so, please, I am very happy to leave the floor to Tomasz Szczapa, and we start with the first presentation.
Thank you very much, Professor Trevisanuto, for such kind invitation, and I would also like to thank for inviting me to join this interesting session. So within the next 20 minutes, I'll try to cover the most important information from the latest update of newborn life support guidelines that was published in spring this year. I will start with disclosure, educational grants from GE and Chiesi, and it is my pleasure to present the guidelines on behalf of the group that was writing them, with John Mader and Charles Rare as co-chairs, and other colleagues, including Professor Trevisanuto, that were in the process of writing and reviewing these. Well, luckily, most of the neonates, most of our patients, they adapt well to extrauterine life, but there are some that require help. And in those, we need to know how to react. We need to have up-to-date knowledge, and we need appropriate skills to help them. And the knowledge regarding the most appropriate approach to neonatal stabilization and resuscitation that evolves with time. And ERC guidelines, they are supposed to be updated every 5 years. However, due to COVID pandemic, the latest update was delayed by 1 year. But in the meantime, in 2020, the COVID resuscitation guidelines, also including the neonatal part, were published. So if you're interested, you can check the original documents. And by the way, the current guideline on resuscitation, the latest update, is available as a free download at ERC website. So on the left here, we can see the previous algorithm from 2015. On the right, you can see the latest one from 2021. You can see that it has got more elements right now. I think it's a little bit more practical. So there are more information already present on the algorithm. So I think it became even more useful, and that also includes the box with elements describing approach to the preterm infants below 32 weeks of gestation. So first of all, in order to be able to provide resuscitation, we need staff that is well trained, that has got up-to-date knowledge, has got appropriate skills, and is also updating their knowledge regularly. The other element that we need is equipment, of course, and environment. So all equipment must be checked and easily available when it's needed, and of course the environment in which the stabilization or resuscitation procedures will be carried out, it also be appropriately prepared with regard to the light, for example, or the temperature, which seems to be even more important. And we need to have the access to all the needed equipment, monitoring equipment, but also some smaller parts of the equipment that we need to use, such as face masks, laryngoscopes, etc. Ideally, if possible, and if there is time available, it's best to consult with parents and also debrief the team, considering risk factors. So with that, we can be better prepared for what is coming. Then when our patient is born, the first element that we need to remember about and to consider is thermal control, as we know that effective thermal care affects mortality and morbidity. So we should prevent the baby from becoming hypo or hyperthermic, because we also need to avoid temperatures which are too high, and we should regularly monitor these babies after birth. It's also recommended that the temperature on admission is recorded, as it is both a prognostic and quality factor. As I mentioned before, we need to optimize the environment. We need to protect the delivery room from drafts. So we need to make sure that the temperature is adequate, 23, 25 degrees Celsius, or for most premature babies, even more than 25 degrees Celsius. And then depending on the maturity, the approach may be slightly different. So for term and near-term infants, at 32 weeks, at above 32 weeks of gestation, we would dry and cover them with dry towel. And if resuscitation is not required, then we would place them skin to skin with mother. If interventions are needed, then we place the baby under the preheated radiant warmer. In preterm babies below 32 weeks of gestation, we may need more interventions, and it's recommended to place these babies undried in plastic wraps, as it allows better control of the temperature. And perhaps in these babies, additional interventions may be needed, such as the use of warmed, humidified respiratory gases, which may also have a significant impact on the temperature on admission. Regarding the umbilical cord management after birth, if there is no need for immediate resuscitation or stabilization, we should aim to delay the cord clamping for at least 60 seconds. And ideally, we would like to perform clamping after the lungs are aerated. So what's new in the guidelines, they say that where adequate thermal care and initial resuscitation interventions are possible with the intact cord, we can do this while interventions are performed. So these initial interventions could be performed with the intact cord. And if the delayed cord clamping is not possible, we may also consider cold milking, but only in infants older than or more mature than 28 weeks of gestation. So that's the new part that can be found in 2021 guidelines with regard to the umbilical cord management. And simultaneously, we assess these patients and provide tactile stimulation. The parameters that we assess include tone and color, breathing, and heart rate. And if we see that the patient fails to establish spontaneous and effective breathing and has got low heart rate, then we need to move on to making sure that the airways are patent and to the ventilatory support. So depending on the condition, there are different scenarios possible with different degree of intensiveness in our actions, so to say. However, if the infant has not established adequate regular normal breathing, if it has got low heart rate below 100, then we need to commence airway support. And usually, if we ensure an open airway, aerate lungs and ventilate the lungs effectively, in most of the patients, that's all that's necessary. However, it's important how we do it. Those babies that are apneic or do not breathe effectively need to be placed under the radiant heater, supine with the head in neutral position to make sure that the airways are patent. Jaw lift, which can be seen on the pictures here in the middle panel, can be very helpful in floppy babies, and two-person methods of airway support and securing the mask can also be very helpful if these patients require ventilation. The suctioning of airways is not routinely recommended, and also in the non-vigorous infants which are delivered through meconium-stained fluid, it is not recommended to perform routine suctioning. So that's also a change in the approach. The primary pressure needs to be put on ventilation. So ventilating these babies as soon as possible when they are apneic. And only if the initial attempts at aeration and ventilations are unsuccessful, then we should consider inspection and suctioning the airways under direct vision, and then try to inflate the lungs of these patients. Again, and in some cases, tracheal intubation may be necessary. If we have spontaneously breathing preterm infants, we should consider CPAP as the initial method of breathing support. In some of these babies, it may be all that's necessary, usually with a face mask, but other interfaces are also possible. If the baby is not breathing regularly, if it's apnea, gasping, then we should start positive pressure ventilation, usually by using a face mask that needs to be properly fitted with a good seal. And according to the RC guidelines, we start with 5 so-called inflation breaths. For term infants, they should be given with initial pressure of 30 centimeters of water with room air. And for preterm infants, the initial pressure was increased with the current edition of guidelines to 25 centimeters of water, and the initial FiO2 between 21 and 30%, depending on the maturity of the patient. And of course, those patients need to be assessed, monitored. In some cases, even higher pressure may be needed if these initial inflations are not effective. If despite effective inflation of lungs, the patient is not breathing spontaneously regularly, then we need to continue with ventilation breaths at the rate of 30 per minute. And we also we should monitor saturation and heart rate. And especially in the preterm babies below 32 weeks of gestation, we should avoid saturations below 80% and bradycardia at 5 minutes of age, as this is a poor prognostic factor. If there is no effect in heart rate or chest movement, we should look for possible reason, check equipment, check head position, mask seal, consider other airway maneuvers, other interfaces that allow better airway control in some cases, such as laryngeal masks, for example. Also consider gradual increase in inflation pressure. If we have a respiratory function monitor, we should also check expired tidal volumes and leak. And then after this reassessment, we repeat inflations in these patients. Airway adjuncts such as laryngeal mask or endotracheal tube may be needed if the face mask ventilation is not effective. There is growing evidence that laryngeal masks can be used effectively, but currently know that this can be safely done in babies that are more mature than that are at 34 weeks of gestation or more mature. If possible, we should use TPS resuscitators, as they are capable of providing CPAP or PPV with positive and expiratory pressure, and they might allow better control of pressures and at the same time tidal volumes that we are using. Alternatively to face mask, we can consider nasal prongs, and of course, if the TPS resuscitator is not available, we might switch to self-inflating back. If despite the ventilation, the heart rate remains very slow, so below 60 per minute, or is absent after 30 seconds of good quality ventilation with chest movement visible, we should move on to chest compressions. And when we are moving to chest compressions, we should increase the FiO2 to 100 according to the current guidelines, and also call for help. The technique which is recommended has not changed from the as compared with 2015 guidelines. So this should be 3 compressions to 1 ventilation, 3-to-1 ratio. Two-handed technique is recommended if possible. We should remember about regular reassessment. Ideally, of course, we should use continuous monitoring with pulse oximetry and ECG that will be discussed in more detail with the later presentations. And in these patients, we should also consider securing airways with endotracheal tube or laryngeal mask, as it may allow better airway control than with a face mask. However, it's optional. It's not obligatory. We should just consider this. When we have a reading from the pulse oximeter, then of course, if the SpO2 values are satisfactory, then we should win the FiO2. If despite ventilation and chest compressions, we still do not see satisfactory response from our patient, then we should consider administering drugs. And usually the default way of administering drugs would be the IV route. However, the intraosseous route is also possible. Usually we would administer drugs in such setting via umbilical vein. Most commonly, usually we would use adrenaline at the dose of 10 to 30 micrograms per kilogram IV. However, if intratracheal route is used, then we need to use a larger dose, 50 to 100 micrograms per kilo. And with the current guidelines, it's recommended to consider subsequent doses of adrenaline every 3 to 5 minutes if the heart remains very low. In the absence of an adequate response at this stage, we should also consider factors which may be impacting this, such as pneumothorax, hypovolemia, congenital anomalies, or equipment failure. And finally, if the heart rate remains undetectable for longer than 10 minutes, there is a risk of poor outcome. And if it continues to remain undetectable for more than 20 minutes, then according to the current guidelines, we should, and of course that's despite the provision of a full protocol, despite the provision of all recommended steps of resuscitation. In such cases, we should consider discontinuing resuscitation. So this period of time is now longer as compared to 2015 guidelines. So that's 20 minutes. And of course, we should, as I mentioned before, exclude the possible reversible causes. So in summary, these top 5 messages that we prepared include delayed cord clamping, which can optimize the condition of the baby, especially in the preterm infants, and can have beneficial effects on the survival and the decreased risk of selected complications. Please remember that the effective thermal care is vital, so we should remember about drying, wrapping, and stimulating these babies. There is increasing evidence that stimulation can also have a vital impact here. Remember about assessing breathing and heart rate, and fast heart rate and also heart rate getting faster indicates good results of resuscitation and indicates adequate oxygenation. We should also remember that in most of the cases, simple steps to support airway and breathing manage problems in babies that require resuscitation after birth. And if we need to move on to chest compressions, we should remember that they will only be effective once effective ventilation was established, and we are considering this if the heart rate is very low. And on the right, you can see the changes as compared to the 2015 guidelines. So regarding the management of umbilical cord, you can see that the cord milking can be considered now, but only in infants which are more mature than 28 weeks of gestation. With the meconium stained liquor, we indicate the importance of lung aeration as the most important step, and only after failed attempts of ventilation in such cases we should consider suctioning. We also underline the possible effectiveness and importance of considering the use of laryngeal masks in infants which are more mature than 34 weeks of gestation. We also indicate the role of regulation of the inflation pressure. So if there is a limited response to ventilation, we should consider gradual increase of the pressure. The recommendations regarding oxygen use have also been changed and more detailed right now. So we should start in air at 32 weeks of gestation or more. We should start between 21 and 30% inspired oxygen and 28 to 31 weeks, and 30% inspired oxygen for the most immature babies below 28 weeks of gestation. So I think I will stop here, and I would be interested to see your questions in the chat. Thank you very much.
Thank you, Dr. Szczapa, for your great presentation. It's very hard. It's really a challenge to do a summary of the guidelines in 20 minutes. Thanks also to because you stay in the time that we gave you.
It wasn't easy, I agree. Thanks.
Yeah, yes, I can imagine. Okay, we move on and we move to the next speaker. The next speaker is Professor Gonzalo Zeballos. He's from Hospital General Universitario Gregorio Marañón in Madrid, Spain. Professor Zeballos is a member of the neonatal group of the Spanish CPR Council and the Spanish Society of Neonatology. The title of his presentation is Practice of Neonatal Resuscitation with Heart Rate Monitoring. And heart rate monitoring is one of the most important aspects that have been studied in the last 5 years from the 2015-2020 guidelines. There are more or less 10 modalities to assess heart rate in the delivery room. I am very interested in the next presentation, and so now, please, Gonzalo, the floor is yours.
Good afternoon. Many thanks to General Electric, the organization, and Dr. Sanuto to invite me to participate in this meeting. For me, it's an honor to share with all of them and my partners this meeting. The topic I'm going to talk about today is how to measure and to know the heart rate during stabilization of newborns in the delivery room. Heart rate assessment is vital at birth to guide neonatal resuscitation. All of us know that this could be a high altitude adventure with its lights and shadows. I introduce the presentation with this sentence because it is essentially true that what is not defined cannot be measured. What is not measured cannot be improved. What is not improved is always degraded. So in neonatal resuscitation, in order to ensure quality CPR, the clinician needs to be able to look and register as many parameters as possible. We know that one of the most important parameters is heart rate, so we have to measure it. The question is, to interpret all these measurements, types of records, perhaps should we focus in one and conduct CPR in order to achieve the predefined targets that may ensure quality? Where on earth to look? In the following 20 minutes, we are going to review which problems we find. Do we have any answers? New findings, new situations, and finally, the conclusions. We are going to start with which problems we find. This is the last neonatal resuscitation algorithm from ILCOR 2020. A difficult part of neonatal resuscitation in the delivery room is subjectively assessing spontaneous breathing and to know what the range or exact heart rate is. In the context of neonatal resuscitation, this is critical information as bradycardia guides decisions about the need for and response to interventions such as positive pressure ventilation or chest compression. The neonatal resuscitation program recommends 6 seconds method of counting heart rate inconsistently used cause difficult mental computation. This is the neonatal resuscitation algorithm from Spanish Society of Neonatology based on Ilker algorithm. In the red boxes, we can see that in neonatal resuscitation, it is very important to know the initial heart rate or start point and recovery of bradycardia events as accurately as possible. Nevertheless, when looking into how long it takes to perform different tasks recommended in neonatal resuscitation, different studies show us that for the majority of the population studied, at the cut-off points of 30 and 60 seconds, the heart rate had not been assessed. Even more, at 60 seconds, attempt rates were higher, but consecution was still low. Guidelines allocate 30 seconds to successfully complete each step after the first minute of life. Think that the median time taken to perform the individual recommended task is longer, we are not being able to comply with the usual guidelines. In fact, caregivers are initiating ventilator support before they have determined their heart rate. The current algorithm supports initiation of PPV in the newborn if the newborn is naked or gasping regardless of the heart rate. In this study performance during high fidelity neonatal resuscitation simulations, results about timeliness, communication, and accuracy of heart rate determination from caregivers by umbilical cord palpation and auscultation are suboptimal, particularly for heart rate between 60 to 100 beats per minute, which may lead to inappropriate decision making and neonatal resuscitation care. Clinical assessment of an infant's heart rate in the delivery room has been reported to be inaccurate. We carried out a descriptive observational study through a survey of pediatricians trained in neonatology. When we asked about which was the most difficult assessment maneuver, most of them agreed that trying to determine the heart rate was the most difficult one, both before and after receiving neonatal resuscitation training. And we can see in the red boxes, globally, a decrease in the perception of difficulty in the maneuvers initially considered more complex is observed, except for the assessment of the heart rate, which remains difficult. And is that during extreme bradycardia with weak pulse, we have a bit of a play guessing the heart rate. So we have to deal with the obligation but the guidelines of assessing heart rate and the reality of our media, which is that we don't feel confident enough even after training to assess the heart rate. And when the tools that we use are evaluated, don't provide us with the information in time. We need more accurate heart rate determination methods than clinical one. Pulse oximeter has been recommended about auscultation and umbilical cord palpation, but this is enough. Do we have other alternatives? Next point is, do we have any answers? Many studies have compared auscultation of the heart rate using a stethoscope with electrocardiography and pulse oximeter for determining the heart rate in newborns, infants in the delivery room. Electrocardiography is considered a gold standard for measuring heart rate, and recent guidelines recommend electrocardiography use when available to monitor heart rate apart. Palpation and auscultation underestimate electrocardiography and pulse oximeter heart rate. Electrocardiography is faster and more reliable than pulse oximeter in the first minutes after birth, especially after immediate cord clamping. After 5 minutes, assessment of heart rate were similar. Heart rate was determined quickly and with reasonable accuracy by auscultation in low-risk newborns, but in high-risk, we can see here, but in high-risk infants or in case of initial bradycardia, electrocardiogram is more accurate and faster after birth or after device application, as we can see in this graphic. It's true that the lying task may be related to the good condition of some infants at birth or infants were vigorous and crying. But all of these studios are performing in preterm babies, and Cateria and Iglesias performance studies in those that require resuscitation. While this suggests pulse oximeter could be used to monitor heart rate at birth, the study by Camley did not examine the first few minutes after birth in the child. Also, Van Vonderen reported pulse oximeter underestimates heart rate in the first 2 minutes after birth. So the reason is that electrocardiography is the gold standard as accuracy, the most quick to register the heart rate. This alternative is the electrocardiography, but the use of electrocardiography also has several limitations. Time need to clean newborn's skin can easily become dislodged, potential signal interference, potential skin injury in preterm premature infants, and especially clinical cases involving high drops, fatality, or pulseless electric activity, which could result in misinterpretation of this applied electrocardiography heart rate. Has associated costs in terms of resources, staff to apply them, and handling of the infant. Also, if we are not able to get the pulse oximeter on time in the newborn, do you think we will be able to get the electrocardiography? We are stuck with the same problem. However, some of these limitations could be solved with an adequate role distribution. The Spanish Society of Neonatology defined this algorithm that I present with a specific role display and resuscitation task, enabling one of the resuscitation to clean the newborn skin and try to monitor the baby with the electrocardiography safely enough. Therefore, the pulse oximetry and electrocardiography leads should be applied immediately while infant received positive pressure ventilation. It can be established that the second rescue assumes the following task: placement of the pulse oximeter when putting on the bag, when putting the baby on the bag, auscultation, and subsequently electrocardiography to increase monitoring accuracy. If there was a third resuscitator, he could place the electrocardiography leads. But as we previously referred, is electrocardiography available for everyone? Sometimes it is not. Even in our media in Spain, most units don't have an electrocardiography to monitor newborn. So role distribution with auscultation of the baby could remain a simple answer in every other circumstances. And now, in one hand, it is clear that we have to do something different. And in doing so is when we find new findings. In the other hand, practice should not exclusively rely on electrocardiography or devices. We mustn't lose the sense of reanimation. Let me show a magnificent example.
Sir, we're bearing it there, isn't it? Yes. Yes, more apparatus, please, nurse.
The EEG, the BP monitor, and the AVV.
Yes, certainly, Doctor.
And get the machine that goes bing!
And get the most expensive machines in case the administrator comes.
Lovely, lovely. Jolly good, that's better, that's much, much better. Yes, more like it. Still something missing, though. Patient. Yes. Where's the patient? Anyone's been back. Patient.
Ah, here she is.
Bring it over here. Mind the machine.
Sorry, Doctor.
Nice, clear. So we mustn't lose the sense of reanimation. It's the passion. We will tackle new methods and new approaches. Is the next step. We have seen how to monitor heart rate in the delivery room in the first 60 seconds and in the next steps of the algorithm to assess their need for intervention and response to resuscitation in the delivery room. Novel technologies could help us for continuous and accurate heart rate measurement during neonatal resuscitation. Ultrasound is a diagnostic tool which increasing application in different emergency situations. Different studies show us that ultrasound is a fast method to detect heart rate in the delivery room and has a good correlation with stethoscope and electrocardiography. Dyson study showed that audible Doppler has similar reliability and accuracy compared to electrocardiography, and need be the most useful technique to assess heart rate immediately after birth. These two images refer to a 10 newborn infant by via emergency cesarean section for a routine placenta suspicion. As the initial assessment, baby was limp, apneic, and hypotonic. Rapid auscultation of the chest revealed asystole. Pulse oximetry and electrocardiography leads were applied immediately, while infant received positive pressure ventilation. Initial heart rate on the electrocardiography displayed 35 beats per minute at 40 seconds of life. Echocardiography, this was the echocardiography, was performed at that time, showing no cardiac activity with a flat right and left ventricles indicating cardiac arrest due to less electrical activity in the context of possible hypovolemia. Epinephrine was administered and immediately volume with ongoing chest compressions. Subsequently, the heart rate detected by electrocardiography was 88 beats per minute, also with bedside echocardiography display, visualizing an effective contraction, as you can see here. Important, Doppler ultrasound requires a dedicated operator. Several papers on the last years have raised doubts about the electrocardiography used in the delivery room, as some childs may have pulseless electrical activity. It is a phenomenon that occurs when cardiac output is zero, but the electrocardiography still displays an heart rate. And there is increasing evidence that pulseless electrical activity occurs in the delivery room. More concerningly, we can rely on electrocardiography display and PA mid-delay the start resuscitation. Ultrasound can help us to decide the optimal moment to include volume resuscitation in the algorithm. It could give us some possible changes in the neonatal resuscitation algorithm with greater importance of intravascular volume administration, helping to guide the cardiopulmonary resuscitation. This suggestion may have significant negative effects on resuscitation because many areas in the world do not have access to electrocardiography or echo devices, but it should be tried with the pulse oximeter. Another device, inclusion of the respiratory function monitor, could help us to establish an optimal ventilation strategy during resuscitation and thus enable better recovery. Tidal volume assessment in combination with heart rate enable a more accurate and individual approach to resuscitation. By using the respiratory function monitor, measuring tidal volumes delivered and CO2 entitled during resuscitation to the baby, heart rate objectives are accomplished earlier compared to measuring heart rate only. Using blank study about normal progression of CO2 entitled in near-term infants with spontaneous birth, and our study in preterm infants receiving positive pressure ventilation, we can see the blue line in how the CO2 entitled progression is faster in those infants where the heart rate has recovered more than 100 beats per minute before 60 seconds of life against the babies that haven't got recovered more than 100 beats per minute before 16 seconds of life. It reflects better cardiac output and perfusion in the pulmonary bed. In addition to respiratory function monitor, using lung recruitment patterns by ultrasound in this context reinforce the heart rate improvement and lung recruitment. In this example of an apneic and hypotonic 36 weeks gestation infant, we can see how increasing the positive inspiratory pressure and PEEP will recruit the lung, getting right tidal volumes between 4 and 6 milliliters per kilogram, and how the heart rate increases initially parallel to rising CO2 and tidal. The ultrasound patterns show us the ideal recruitment moment and its relationship with the other parameters. It reflects how different devices may be able to gauge resuscitation. Novel technologies can support heart rate assessment, but presently there are no studies to validate their clinical efficacy during neonatal resuscitation. The evidence was in infants not requiring resuscitation and therefore constitute an indirect form of evidence. The photoplasmography device is an optical technique that detects blood volume changes in tissue microvasculature. It's continuous, non-invasive, and use light-emitting sensor and photodetectors. Moreover, have similar accuracy compared to electrocardiography heart rate values. In a recent study by Guletti, a novel technique has been suggested to overcome this delay by presenting electrocardiography electrodes and the bed for attachment to the infant's back, while also allowing for chest compression not to interfere with electrocardiography signals. Either evaluated in infants requiring a resuscitation. Johnson's study with NeoTab life support suggests good results in accuracy and timeliness in a model of neonatal asphyxia. Previous studies are from simulation. So finally, the conclusions is that we have to include an objective heart rate monitoring technology early in resuscitation as unusual measure in the delivery room. Ideal features include continuous, non-invasive, and fast acquisitions of an accurate heart rate. Of course, we recommend the use of electrocardiography when in doubt and when available. It can be performed bedside real-time feedback, monitors clinical and treatment change. Electrocardiography monitoring is the fastest and most accurate to detect change in heart rate, but healthcare professionals should not solely rely on electrocardiography for heart rate monitoring alone, and rather use a combination of techniques. Rapid and continuous interpretation of heart rate influences adequate treatment and help to rule out cardiopulmonary resuscitation. While using technology to determine heart rate incurs delays and costs, it is possible that insufficient team training at our hospital was responsible for the failure to complete tasks within the recommended time frame, and that more training will improve performance. Even though we recognize the measure in heart rate is still not an easy task, the best way to deal with it is through training and establishing simulation training programs of resuscitation in the delivery room. A team approach to training may improve heart rate assessment. That's all. Again, many thanks to the organization, and any question, I will hear for you. Many thanks.
Thank you, thank you, thank you. Thank you, Professor Sarrato, for your very nice, very interesting presentation. Now we move to the last presenter. The last presenter is Professor Eszter Bodrogi. She is head of neonatal service at the NICU hospital in Bucharest, Hungary. She's also a consultant at the Imperial College Hospital in London. The title of Professor Bodrogi presentation is from L&D to the NICU, intra-hospital transportation matters. Please, Professor Bodrogi.
Thank you, and good afternoon to everyone. I'm feeling very, very honored to speak in such fantastic company. Just one thing to begin with, I'm not a professor. I don't think I will ever be, but you never know. I'll let you know. But thank you so much for the honor. I'm quite lucky, actually, I think, because I get to talk here about a topic that is probably one of the favorites of every neonatologist, and this half an hour, 40 minutes after a delivery of a preterm infant. And I'm also quite lucky because I think, as opposed to many other fields of neonatology where there's a lot of controversial data and issues around, and it's sometimes really hard to find our way around, this is actually an area where there is a nice, good evidence available for anyone. And this is the form of the European Consensus Guidelines, RDS Guidelines, we call it. And we've had that guideline, I think, from 2013 onwards. And there is a lovely group of people, scientists and clinicians, who sit down every 3 years and collect all the emerged evidence and incorporate it to the next update. So the last one we have out is the one from 2019. And I look at this guideline really as a fantastic recipe from a cookbook, really, where you have the appropriate ingredients, which in our case is the equipment. We need to do this properly, and you follow the steps that are written down in the guideline meticulously. Then actually at the end of it, you have a very good chance that you're going to have a fantastic dish. And the dish in our case, obviously, is a healthy, lovely newborn preterm baby. So what I'm going to do in this 20 minutes now is that I'm going to just quickly run through the bigger or most important topics of the RDS guideline as the basic elements that tells us what to do when a preterm baby is born. And then I'm at the end going to show you that how we have incorporated that into a practice, which we believe is quite a good practice, although it still has its pitfalls, and I'm sure there is a lot of place for us to improve as well. So we have talked about this, some of it in the first talk of this session. Delayed cord clamping is one of the things that is well established now, that it's beneficial and improves neonatal outcomes. So the RDS guideline advises us to delay the clamping of the cord for at least 60 seconds to promote placenta fetal transfusion to the baby. But as it was said before today, there is a growing evidence now that instead of just setting a certain time to clamp the cord, what we should rather do is that we should do something like we call physiological based cord clamping, which is meaning that the cord is just clamped and when the regular respirations is established. And whilst this is happening, we should apply. Now, this is very much a device-dependent procedure, and although there are devices around the world for us to be able to do this properly, but I think there is still a lot of improvement, a lot of scope for improvement for big companies like GE or anyone else actually to come up with an ideal solution for this. The other big topic is what we do have to take care is at resuscitation is thermoregulation. Again, it's been discussed before today. So for preterm babies, we have to be extra careful. And the reason why we have to do this is that there's still about 50% of the babies who we admit to the NICUs have low temperatures. And we know that every decrease in the NICU admission temperature contributes to a huge increase in mortality and increase in sepsis later on life. So we are advised to use plastic bags or other type of wrapping under radiant warmers for anybody below 28 weeks gestation. But there is an other side of this, and showing that we really do sometimes fall off on the other side of the horse, because there was a nice paper in pediatrics that compared 2-year periods 10 years apart, so 2012 and 2013 compared to 2002 and 2003, and they found which is fantastic, that the percentage of the normal temperature in babies who were admitted to NICU have actually doubled in that 10-year period. But they also found that those babies' numbers who were admitted to the neonatal units hot, so overheated, tripled. And we very well know the adverse effects of hypothermia, but we also have to know that overheating preterm babies, and especially the very little ones, can also have quite detrimental adverse effects later on life. So that's something we really still need to be prepared to watch out for, and either use servo-controlled thermometers or just keep a very close eye on a baby's temperature, and as it was said before, measure and record it regularly in the stabilization and transporting period. Other big category, oxygen and saturation. So obvious again, we use oxygen for resuscitating babies. We use a fraction for the little tiny ones. So the advice now is to use about 30% for babies under 28 weeks and a little bit less as the gestational age grows. And we then adjust the applied FiO2 guided by the pulse oximetry. And obviously we deliver oxygen using a blender. And again, as it was said by Professor Szczapa before, that babies under 32 weeks gestation should reach an FiO2 of 80% and a heart rate above 100 within their first 5 minutes of life. The mode we support their breathing is well established now again. CPAP should be started for babies who are at risk of RDS, so potentially everyone below 30 weeks gestation. This can be delivered by any device really, but we should be using binasal prong between 6 to 8, but some centers use much higher pressures than this. We should not use sustained inflation. That has been a time when this was questioned a lot, but there has been no long-term benefit studied. And if a baby remains persistently apnoic or bradycardic, then we should use a gentle positive lung inflation with the pressures about 20 to 22 water centimeters to try and inflate the lung. Intubation should only be kept for babies who do not respond to these, what we've just mentioned above. And all those babies who require intubation at delivery suit, they do need surfactant as well. So CPAP with early rescue surfactant is the optimal management for babies, as opposed to in previous years where we used to just give surfactant in the first couple of minutes of life. This has changed in these new recommendations, and we try to stabilize everybody with CPAP first and go for surfactant a little bit later on if the oxygen requirement creeps up above 30%. So after just running through all these major categories, what the guidelines suggest us, we get to the point of transfer. And the conventional way of transporting a baby after delivery involves a lot of things, really. At one point, the baby gets from the mother's bed to a resuscitator. Then from a resuscitator, they get we do the stabilization, and once baby is stable, we transfer them to a transport incubator, and then the transfer happens there, and then from the transport incubator, we take them to the NICU incubator. And if worst come to worst, we even put them on a weighing scale between these two things. So at least 3 or 4 moves for just one single baby in the first hour of life or so. And we all know that they hate this. So even if they don't want to die, as Prof. Gaylord said once, but every time we try moving a baby, even a well baby, they deteriorate, they don't like it. And we know this from experience. It's a risk of stress, it's a risk of them getting cold again, and there is a huge risk of equipment failure, because the more devices we use, the more the chances that some of them will just decide not to work for it. So instead of that, what we use is a combination of the giraffe shuttle and the giraffe omnibed, which actually does all these things together for us. So here on the pictures, you can see the equipment, what we use for our practice. The giraffe shuttle which is looking like a little Christmas tree on behind behind that daddy on the picture, is able to give you about 45 minutes of power, so you can walk quite far with it without having to be plugged in. It can accommodate all the equipment that you have or that you need for stabilization of the preterm baby. So it can accommodate a CPAP, any kind of device, or a ventilator for that matter. It can accommodate the humidifier. It obviously accommodates the GE Star, which does the inflation, breath, and suction for you if needed. You can put a monitor in it, any kind of monitor. It can also house 2 big cylinders for the oxygen and air supply for the transfer. And despite all of its big size and chunkiness, it is quite easy to navigate. And the best thing about it, I think, is that you can attach a lot of compatible GE products to it, obviously. So all the GE incubators are attachable to it. So this is the equipment we use, and this is how we do it. And before actually showing you how practice works and how it goes in life, just one more topic I want to talk about is neurodevelopment, because I always find it quite fascinating that thankfully these days there is a huge interest and a huge emphasis on developmental care in neonatology. And we have fine courses, and we had NITCAP before, and we know exactly how these babies should be positioned and how they should be kept from light and sun, and how should we minimize the stress they receive. It's quite fascinating, I think, that a baby's brain at 24 weeks looks like this little, I don't even know, chestnut maybe. And it is really in our hand to make it looking like this, that you can see on the right-hand side, this lovely detailed structure at about 40 weeks. And remember, these tiny babies do spend this time of their lives with us. So it's all in our hand to make this happen. And they come from an environment which is absolutely ideal, that you can see on the left side of the picture. So we have to really do our best to make it not looking like this. And that's why I crossed it off with a red line. Not looking like this when we stabilize or even resuscitate them. So we have to, I think, I know it's a huge task, but I think in this first 30 minutes of life, we still have to bear in mind developmental care, and still we have to do our best to try and save them from stress as much as we can, protect them from light and sun as much as we can, and keep their position as close to the intrauterine position as much as we can. Obviously, at the same time, being able to stabilize them. So I think these are the aspects that we try to keep a close eye on when we work and when we stabilize a preterm baby. So let me just now show you a video of how we exactly do it. And with that, I thank you for your attention. Can I just have the video from the team there?
And so thank you to all the speakers for this very nice and very interesting presentation. And thank you to Professor Bodrogi for this last video that is the summary of all the things that were presented by previous speakers. You put in practice what they said in theory, and so I enjoy it also because you added another how to say information, very important information, that is the care or the gentle care of this patient that we have to take into account every time we are there, in particular during the first minute of life, because as you said, they really count. I think that we have not time because we have out of the time now. I would like to insist or invite the audience to send a question to our speaker, because today we learned many aspects, many new things. For example, Tomasz Szczapa presented a very populated algorithm that is different from 5 years ago. And so why you added all this information? And Gonzalo, Professor Sarrato, presented a new modality to consider rate evaluation that we know is the most important information or marker of what we are doing in the delivery room. And so that is very important. And Eszter Bodrogi say that, okay, we do everything, but please take care of every aspect, the sound, the light, and every aspect count. And we have the technology to do it. I would like to conclude our symposium again, saying thanks to General Electric Healthcare for organizing it and for inviting us in this meeting. I hope to have to receive many questions for the audience, and bye to the next. See you to the next meeting around Europe. Have a good day. Bye.
Many
Bye.
thanks. Bye. Very much.